Welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and this is my pleasure to co-moderate this digital event with Dr. Nizar Mahlaoui. Hello, Nizar.
Hello, Martine. Hello, everyone. Welcome to all of you. I'm Dr. Nizar Mahlaoui. I'm a pediatrician in immunology and hematology here at Paris Necker Hospital, and I am the chair of a medical advisory panel of IPOPI. I'm glad to co-moderate this event together with Martine Pergent.
First, let me take a moment to thank our sponsor, Chiesi, for making this event possible. The theme today is ADA-SCID management from diagnosis to treatment. But before we start, let me remind you the IPOPI Hard Talks concept. With IPOPI Hard Talks, we have explored the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. To engage in this discussion, I am delighted to welcome our challenger today, Professor Fabio Condotti from Switzerland. Professor Condotti, you are a full professor of medicine at the University of Lausanne and head physician in the Division of Immunology and Allergy of the Lausanne University Hospital. You received your MD from the University of Brescia, Italy, and completed your residencies in pediatrics and pediatrics allergy and immunology at the University of Padua and Brescia, still Italy, before joining the National Institutes of Health in the US as a postdoc in the field of gene therapy. You currently serve as president of the European Society for Immune Deficiency, associate editor of Pediatric Allergy and Immunology, and specialty chief editor of the Primary Immune Deficiencies sections of Frontiers. Welcome and thank you.
Thank you very much, Martine, for the invitation. It's a pleasure to be here with you all today.
Thank you, Fabio. And my turn to have the pleasure to introduce our presenter, Dr. Reem El-Feki. Originally from Egypt, you earned your doctorate in pediatric immunology from Ain Shams University in 2013 in Cairo, Egypt. You were later awarded an MD in residency in bone marrow transplantation and immunology from UCL London in 2020 for your coordination of a clinical trial on haploidentical transplantation using genetically modified T cells. You have held several prestigious positions, including consultant in bone marrow transplant at Bristol Children's Hospital in 2021 and consultant in adult immunology at the Royal Free Hospital in London 2020. And since 2022, you have been serving as a consultant in pediatric immunology at the Great Ormond Street Hospital in London. We're very honored to have you with us today. Welcome.
So welcome to both of you. And how will this hard talk work? The El-Feki will soon give her lecture. After the lecture, Professor Condotti will share his comment, and together they will discuss and debate the topic. But during the presentation and the discussion between our two guests, you will be able to send written questions in the question tab. So let's begin. Dr. El-Feki, the floor is yours.
Thank you very much, Martine and Nizar, for this opportunity. So I think you are uploading the presentation. Yes. Martine, can we go to the first slide? Yes. Okay, thank you. So I'll start with the talk today. It's ADA-SCID management from diagnosis to treatment. And the objectives of this talk that I will first outline what is ADA-SCID, and I will show data about diagnostic pathways, treatment options, patient perspective. I will give you some insight on the late onset ADA-SCID, reflect on some financial challenges with the treatment approaches, and future perspective. So first of all, I think I need to put this alert slide to say that the adenosine deaminase, there are two iso enzymes of adenosine deaminase, the ADA1 and the ADA2, that are responsible to convert adenosine and 2-deoxyadenosine to inosine and 2-deoxyinosine. The talk today is not about ADA2, it's only about ADA1, which is present in all cells, and deficiency lead to severe combined immune deficiency. So what is ADA-SCID? So this is considered a lethal genetic disorder due to adenosine deaminase, ADA1 enzyme deficiency. And this is in chromosome 20. It is autosomal recessive inheritance. And there are almost more than 70 mutations. Most of them are missense mutations. Incidence in Europe is between 1 in 375,000 to 1 in 660,000 live births. And ADA-SCID represents 10 to 15% of the SCID diagnoses, and the phenotype is usually with the very low or absent T cell, B cell, and NK cells. And just to give you an insight into the pathophysiology, so adenosine deaminase inside the cell is very important in order to change adenosine and deoxyadenosine, as I said, to inosine and deoxyinosine. So when the cell dies, there is DNA released, and adenosine and deoxyadenosine are released. And then they should be removed to produce hydroxytensine at the end, and uric acid. However, the problem when there is the adenosine deaminase is deficient is that there are toxic metabolites that are going to build up inside the cell and in the plasma that are going to be responsible for the death of multiple cell lines through different pathways. There will be in the immune cell is and the thymocytes, the T cell have lots of abundancy of the adenosine deaminase, so they are very much affected by the lack of this enzyme. And with this, there will be a signaling defect, there will be a death of the cells, and there will be a problem with antibody production. So patients usually with this lymphotoxicity develop low to absent T cells. They can have low to absent B cells and low to absent NK cells. And the key lab features is that we have low or absent ADA catalytic activity in the erythrocytes, or increase DATB or the deoxyadenosine levels in the erythrocytes, which are the toxic metabolites. And based on the level of the ADA catalytic activity and based on the level of the metabolic products that are present in the packed RBCs, patients can be divided into different categories. So the first category, which is most of the patients, is 80% of the patients, they develop the early onset severe combined immune deficiency, where they get severe infections very early in life, and it is lethal if there is no intervention in the first year of life. And then there is a less severe form, which can be either the delayed or the late onset based on the timing of the onset of symptoms, where patients have some residual ADA activity. So they are the cells are not very much loaded with toxins, and patients have late presentation, and this represents 15 to 20% of the cases. And there is what we call a benign or a partial ADA activity deficiency, where the ADA catalytic activity is not present in the red cells, but is present in other cells, other nucleated cells, which is the lymphocytes. So patients do not have immune deficiency. So going back to what is symptomatic ADA-SCID, so patients mainly present with failure to thrive, severe recurrent opportunistic infection with any pathogen, viruses, bacteria, or fungi. Main fungus is Candida, and different bacteria, opportunistic or non-opportunistic infections. And this is a case with the CMV pneumonitis. They are also susceptible to vaccine-driven infections, so BCG, live-attenuated bacterial vaccination. And you can see here a patient having BCGiosis or these lesions in his skin, which is because of disseminated BCG in the skin before any intervention. This is a patient who had chickenpox. Patients can have problems with rotaviral enteropathy if they got the rotaviral vaccination. And this is a patient actually from Egypt who developed poliomyelitis after the live polio vaccination, because not all the countries in the world are giving the killed polio vaccine. ADA-SCID, as I said, this enzyme is very important in all cells. It's not just immune cells. So there is the extra immunological manifestations of ADA-SCID. And this slide is just summarizing the clinical presentation of the patient. Ranging from cognitive and behavioral abnormalities in a large cohort of patients. And there has been lots of studies in mice model looking at where exactly is the ADA activity important in the brain. And it was shown that it is present from this graph, that it is present in the olfactory bulb, it is present in the cerebellum, cerebrum, thalamus, hippocampus. And this probably reflects why patients will have cognitive or behavioral abnormalities with ADA, ADHD, and autistic spectrum. And this is actually a scan of one of the patients who have dilated ventricle and brain atrophy. The other problem is sensorineural hearing loss, which is actually reported in a large cohort of patients. I will go through this later. And the third thing is what we call alveolar proteinosis. And this is, again, because of the defect in the absence of the enzyme. There is accumulation of surfactant inside the alveolar system, and patients have developed interstitial lung disease. And it is always difficult in a patient with SCID to say, is this an infection related or non-infectious related? And we usually do a bronchoalveolar lavage or and nasopharyngeal aspirates, and we don't find any infection. But with further assessment, we can see that this is alveolar proteinosis, is some form of toxicity of the lung because of the enzyme deficiency. There have been also reports from autopsies of patients with ADA-SCID that they have also adrenal, there is adrenal affection, there is mesangial sclerosis of the kidneys, and there has been some reports of some patients developing atypical hemolytic uremic syndrome, again because of the toxic metabolites. Patients can also develop hepatitis, and there are few case reports of hepatocellular carcinoma. And in a very recent data collection, there was reported cryptorchidism in males. And the other thing is bone affection with rickets-like changes, as you can see here at the end of the bone. And sometimes they have also widening of the costochondral junction. The most important thing to highlight in this slide is that different studies have showed that there is a potential for reversibility of these extra immunological complications, particularly the lung, the liver, and the bone following enzyme replacement therapy or further therapies that can correct the ADA-SCID. However, the two points that cannot really be corrected by any replacement therapy is the cognitive and hearing deficits. There are also rare associations with ADA, and there are in the literature so far, there are 9 reported cases with lymphoma in different organs of the body. And this is just a patient who had lymphoma of the brain. 5 of these patients, the lymphoma appears to be EBV related. And what is very important to mention here is 6 out of the 9 patients reported had developed this lymphoma while being on enzyme replacement therapy between 3 to 17 years. And I will come back to this in a few slides later. The other problem is localized skin cancer called dermatofibrosarcoma that's usually only treated by excision. And there are no cases of metastasis from this cancer, but it is reported in one series in 8 to 12 patients. And again, some of these patients have been on enzyme replacement therapy. So diagnostic pathways, probably you are aware that we are doing now across all the states in the United States and in different centers in Europe. We are doing newborn screening for severe combined immune deficiency, looking at T-cell receptor excision circles from a dried blood spot. And this has been started as a program in 2010 in the US, and then subsequently it is now in different European countries. There is also another technique for newborn screening, what is called tandem mass spectrometry. So it's again a dried blood spot, and they look for the toxic metabolites, and this will only diagnose the ADA-SCID where the toxic metabolites can be detected. And there is definitely the symptomatic patients, as I just highlighted. And there is also the positive family history. As I said, it is an autosomal recessive. So if there is a child that was affected and mom is now pregnant in another child, we can screen the baby at birth and diagnose if this is ADA-SCID or not. And then there comes the confirmatory test, which is the flow cytometry, looking for the absent or low T, B, and NK cells, ADA enzyme activity, checking it in erythrocytes, and checking the level of metabolites in erythrocytes. And of course, subsequently doing the genetic testing to confirm the presence of an ADA gene mutation. So management of ADA-SCID. So there has been, since the ADA-SCID has been diagnosed and identified as the genetic cause of SCID, there has been lots of trials about how can we replace this enzyme that is deficient. And the first trials were in late 70s and 80s, where doctors went for red cell transfusions. However, patients needed to have red cell transfusions every 2 weeks. There has been some response to red cell transfusion with the improvement in ADA activity, but this was not a lifelong response, and patients start to have infections later. And also with the red cell transfusions every couple of weeks, there is the risk of iron overload. And then there was a movement in trying to produce, to give the enzyme to the patient. And this is through bovine beg ADA. This was started in 1990 in the United States, and in the 2000s was available in Europe. And pegylation is actually a process that was pioneered in 1970, and this involves covalent attachment of numerous strands of BEG, this molecule, to a molecule, for example, an enzyme or protein. And the idea of putting this BEG to the bovine ADA is to allow this compound to circulate for a longer period of time, and instead of minutes to days in the blood. The molecule, because of its size, it is protected from cellular uptake, from proteolytic attack, from renal clearance. So again, it stays longer in the circulation. And pegylation itself should be reducing the immunogenicity of the protein. However, there was some patients who developed actually antibodies against the bovine ADA, because it's not human, as you'd expect. And in 1996, there was some, it appears that some the variant of CJD appeared, and there were lots of concerns about the bovine beg ADA. So the manufacturer was looking at producing bovine beg ADA from areas where this virus is not present. And then in 2018, the movement was to produce the recombinant human beg ADA, which is Rifkovi. And this is one of the very important papers that was done by Poppy Gasper, looking at patients who had been on enzyme replacement therapy from April 1986 to September 2008. And this was 185 patients. And was looking at, this is a survival curve, and was looking at the survival, 20-year survival. And we can see after enzyme replacement therapy, 20-year survival is 78%. Most of the deaths, as you can see here from the red circle, 40% of the deaths is in the first 6 months of therapy. And this is probably reflecting severe infections rather than the effect of the enzyme replacement therapy before starting enzyme replacement therapy. And if you can see that death start also is not flat after the first 6 months, and some patients have lost their life as well, with what happens with waning immune system over time and development of antibodies to beg ADA, and this was the bovine ADA. And patients actually with the waning immune system, they start to have late death because of refractory hemolytic anemia, because of chronic pulmonary insufficiency, and because of lymphoproliferation and lymphoma. What is very important is that it is expected for a patient who is alive in 6 months after starting ERT, that they usually should have, what was the conclusion from the paper, they should have 90% probability of survival for the next 12 years. And again, this is a very recent publication, a multi-center study looking at the effect of the enzyme replacement therapy. It was a mix between patients who have been on the bovine big ADA and the patients who have been on the recombinant big ADA. But what was clear in the patients who used Rivcovi is the recombinant big ADA that this allowed detoxification, and you can see a decrease in the deoxyadenosine levels with good immune recovery, and the safety profile with good safety profile noted up to 30 months of follow-up. And this is again another important publication from the BIDTC in the United States, looking at the 131 patients who have the ADA-SCID and the treatment option. And here there is a 74 patients received the enzyme replacement therapy, either only or have been receiving enzyme replacement therapy before going for stem cell transplant or gene therapy. And the most important thing in this paper is if you can see here, this is the level of T cell recovery. This is at the time of the diagnosis, this at 6 months, and then 1 year, and then 2 to 5 years. You can see that the highest is actually at 6 months, that there is good immune recovery, and then things starts to wane by time, what we have already seen in the previous curve by Kopi-Kesper. And if you look at the numbers, the median here is the median T cell counts is still lower than a normal immune system. And also, if you look at the percentage of patients off immunoglobulin replacement therapy, in the first 6 months, 10% were able to be off immunoglobulin replacement therapy on the enzyme replacement. And by 2 to 5 years, it's only 13%. So there is no difference as patients remain on VEG-ADA without any curative intervention. So the second way and the curative option for management of VEG-ADA is the stem cell transplant or gene therapy. And here I will just discuss stem cell transplant first. And this is actually historic multi-system data from the Inborn Air Working Party, multi-center data from Inborn Air Working Party. Here, 106 cases from 16 international centers had a stem cell transplant between 1981 to 2009, and overall survival is 67%, and the median follow-up was 6.5 years. And I want you to have a look at this curve. It's showing that patients of a matched sibling donor, this is again a survival curve, and this is time post-transplant on the x-axis. And here, the patients who had a matched sibling or matched family donor has almost 80% survival. Patients who have mismatched donors or haplotransplant has survivals of 40% or even less. Also, this is a very important graph. This is again a survival graph showing that patients who received an unconditioned transplant again had 80% surviving, but any conditioning was associated with dismal outcome 60% and lower than this. This is historic data. And now this is the most recent data, and this is data from Great Ormond Street Hospital. And this is 28 cases who received 31 HSCT from 2001 to 2019. Median follow-up similar to the previous study, the historic data, 6 years. And you can see there is improved 10-year overall survival and event-free survival, where event is death or or need for a second intervention. So overall survival was 85%. And the event-free survival 71%. And what is very important here is that there was no donor effect. So this is the event-free survival, so surviving without having any requiring any intervention. So you can see matched sibling did not actually, according to the curve, it seems that this is the poorest outcome, but as you can see, there is no significant. The differences was not significant. The most important thing is that mismatched, matched, unrelated, matched family, it was similar outcome. In the matched sibling cohort, it is important to highlight that 1 in 4 unconditioned transplant require second intervention, and most of the matched sibling patients have done unconditioned transplant. Of course, as a complication of transplant, acute and chronic GVHD are one of recognized complications after any transplant. And in this cohort of patients, 18% of the patients developed chronic GVHD. But interestingly, 3 out of the 4 who developed chronic GVHD had actually a matched family donor, not a mismatched graft. And then the pie chart is representing the late effect in 21 cases who survived more than 2 years post-transplant. And I would like to highlight that while 19% of the patients did not have any problems, there is 47 of the patients who had hearing loss and 28% who had learning disability, which is the same as I said, the cognitive and the sensory hearing loss cannot be corrected by enzyme replacement or stem cell transplant. This is another new data about the transplant in ADA-SCID, and this is data from Newcastle Children's Hospital, and again showing similar improved 8-year overall survival and event-free survivals to 90% and 76%, and again no donor effect. Here, what is very important to highlight is that the patients who were transplanted after the year 2007 has actually very high survival, almost 100%. As you can see, there is also only 2 haplo patients, so I would take this with caution, but it's just promising results for patients with ADA-SCID, even if they don't have a matched donor. And the other thing is that here, this is the conditioning curve. So you remember in the historic data, we said unconditioned transplant was associated with better outcome, but in the more recent data, conditioning, like with the minimal conditioning with thiosulfan, was associated with 100% survival in this cohort of patients in comparison to unconditioned or myeloablative conditioning. And in this cohort of patients, they did not record any chronic GVHD, and there were 1/3 of the patients had between grade 2 and grade 3 acute GVHD. It is important to highlight that almost 1/3 of the less than 1/3 of the cohort required immunoglobulin replacement therapy, and most of these patients had received an unconditioned transplant. So conditioning is important in order to get the patient off immunoglobulin replacement therapy. Management of the other way of the curative intervention is through gene therapy. And just to go through the concept and methodology of gene therapy, so this is the stem cell, which is present in our bone marrow. And if we do any gene therapy or any gene editing, any change of the genetic material of these stem cells, this will affect both our myeloid progenitor cell that produce the red cells, the platelets, and the erythrocytes, and will affect the lymphoid progenitor cells that are responsible to produce the B cells, the T cells, and the NK cells. So if we do a gene therapy for the stem cells, we will get the correction of the B cell, T cells, and NK cell in a patient with ADA-SCID. And how is this done? So we use initially people were using the retroviral vector. So a vector is like a truck where it carries the correct ADA gene and put it inside the genome of the patient. So the patient's stem cells are initially corrected from the bone marrow. This is the baby, and we get a bone marrow sample. Or now we are getting mobilized peripheral blood stem cells from the baby. And then we expose it to this retroviral vector that carries the corrected ADA gene. And with the corrected cells, we are able to infuse back to the child who will receive some chemotherapy in order to allow the engraftment of these corrected cells that carry the corrected ADA gene. And as expected, it was a long journey. And if you can see from the numbers first, from the years 1990, 2001, 2012, 2016, you see there is like a decade between movement from one thing to another. The first trials of trying to do gene therapy for patients with ADA-SCID was actually in 1990, and this goes back to Professor Place and Professor Anderson in the NIH, and they tried to correct to put the correct ADA gene in lymphocytes in order to allow correction of ADA-SCID. And actually, the first patient has been corrected and was showing good enzyme activity. However, subsequently, this was not. It showcased that we can correct the lymphocytes, but we wanted to correct the stem cell and correct other elements of the immune system through this gene replacement therapy. So this led to a movement after 10 years. So with the collaboration between UCLA, between Gosh in UK, and between San Raffaele in Italy in 2001 to produce gamma retroviral gene correction in stem cells. And this is the graph below is actually the retroviral vector that was used. It's called the MNZ ADA-SCID retroviral vector. And the patients had some engraftment. However, it was again not a sustained engraftment. And at this time, there was a movement in the bone marrow transplant field to give some conditioning to the patients. And actually, Professor Alessandro Aiuti in San Raffaele in 2002, he started giving busulfan to the patients to allow the engraftment of the gene corrected cell. And this was like a game shifter. So this has led to very successful gene therapy for patients with ADA-SCID with sustainable engraftment and good immune recovery. However, at this time, there has been lots of concerns with other retroviral vector in other diseases, gamma chain SCID and CGD, that some of these patients had developed malignancy post-gene therapy. And with the concern about the use of this retroviral vector, there was the movement to how can we produce a lentiviral vector. And this goes back to the efforts of Adrian Thrasher and Poppy Gasper, who collaborated with Koen Toneld and developed a lentiviral vector that can put the ADA gene in stem cells and allow a safety profile with no insertional mutagenesis and genotoxicity with the vector. In 2016, there was an approval of the use of retroviral vector in ADA-SCID. However, it's only present in Milan. But it's approved in the EU, so most of the EU patients can have access to this therapy if they travel to Milan and get it. And subsequently, there was a movement to produce, instead of a fresh stem cell infusion with the gene corrected cell, to freeze these stem cells and give it to the patient later, so what we call cryopreserved stem cell. And just to say why there was, so as I said, I highlighted with the use of the retroviral vector, the same vector, but with a different gene, which is not the ADA gene, for example, the gamma chain or the CGD, there have been reports of leukemia because of the vector being inserted in areas that are very close to proto-oncogenes, genes that can lead to malignancy. And in order to make this vector more safer, this was the movement, as I said, to the lentiviral vector. So it removed what is called the long terminal repeats, which are enhancers that are responsible for the genotoxicity. It changed the type of the promoter that was used from to a much safer promoter. And this led to, and there was no reported the same insertion next to proto-oncogenes with the use of this lentiviral vector so far. So this is the long-term data on the use of the retroviral vector in ADA-SCID. This was a phase 2 gene therapy trial from 2009 to 2012. And this included 10 ADA-SCID patients who received the gene therapy between 3 months to 15 years with a follow-up of 8 to 11 years post-gene therapy. And you can see 100% of these patients have survived. 9 of these patients have already sufficient immune reconstitution to protect them against serious infections. And only one needed to go back to the use of enzyme replacement therapy. And this was the first patient in this table who had also who were infused with the lowest stem cell dose in comparison to the other patients that received the gene therapy. And 4 out of the 9 were able to get off immunoglobulin therapy. And this is just talking about this graph is just showing the stability of the vector copy number in the peripheral blood mononuclear cells at 11 years post-gene therapy. And here you can see this is the T cell recovery that is stable across time in patients who had this type of gene therapy. However, you can see from this curve is that some patients did not really do well, as this patient, for instance. And actually, this is a very important graph here, where they were looking, at the absolute lymphocytic count in comparison to the age of the patient post gene therapy. And patients who had received the gene therapy very early in life, in the first 3 months, were able to reach an absolute lymphocytic count of 1,000 in comparison to patients who received the gene therapy at 8 to 15 years, where their immune recovery was much poorer. And they reported with the use of this retroviral vector that there was, as I said, insertion near oncogenes in 6 out of 10 patients. But it was not until recently that one patient had developed a TALL and had insertion need a proto-oncogene for a long period of time without having any problems until 4.7 years of gene therapy, when he divided this malignancy. So moving from this, I will show you the data about the lentiviral vector. And this is a phase 2 gene therapy trial from 2012 and to 2017, including 50 ADA-SCID patients. 30 were treated in the United States and 20 were treated in the UK, with a follow-up of 36 months. And you can see 100% overall survival at 24 months post-transplant, post-gene therapy. And 2 patients required either a second intervention or had poor engraftment, requiring beg ADA to be restarted, or stem cell transplant. And again, you can see excellent immune recovery across different cell lines, the T cell, B cells, and NK cells, whether in the UK or the US study. And this is from the same paper. They show the UCLA team have shown that the cryopreserved formulation allowed similar results to the fresh products. So stability of the vector copy number in patients who had cryopreserved or fresh product, the blue and the red, and similar ADA activity and similar immune recovery. And this is the BIDTC report from the United States for 131 patients with ADA-SCID transplanted between who had received the treatment between 1982 and 2017. And what is very important about this paper, first, they showed that 100% survival post-gene therapy in the patient reported according to until this time of reporting. But what is important is that the patient who had a transplant after the year 2000, in absence of an active infection, regardless of the type of donor, they were able to achieve similar overall survival to patients who received gene therapy. So I think this is, again, saying that patients who are probably from areas where there is no gene therapy, there is a potential to use a mismatched donor or a haplotransplant. If the patients do not have active infection, we are expecting a good outcome rather than a poor outcome. And this is the current consensus management approach for ADA-SCID that was published by Donald Cohn from UCLA. And it said if there is a patient with ADA-SCID, then we should be starting enzyme replacement therapy to avoid any opportunistic infection. By this time, we should be looking for tissue typing, looking for an HLA matched sibling or matched family donor, or if the patients can be considered for gene therapy, either he will move to gene therapy or the matched sibling or matched family donor. If the patient does not have, based on family choice, if the patients cannot have gene therapy or they refuse gene therapy, then matched sibling or matched family donor. If there is no matched sibling or matched family donor, then patients need to continue on ERT and the enzyme replacement therapy, and we need to look for alternative donors, matched unrelated donor first as first to be considered, followed by mismatched or haplotransplant. And then here I just wanted to give you some patient perspective from our long-term follow-up clinic and transition clinic in Great Ormond Street Hospital. And I'm really grateful for the patients and the carers who allowed me to share their testimony about their journey. So Atia is a 17-year-old girl who attended the transition clinic to to be followed by the adult immunology team at Royal Free. Asia has received a reduced intensity conditioning 9/10 1DQ mismatched cord transplant in 2009. Before the transplant, and this is the era where there was no newborn screening, she had ICU admission with BCP, CMV pneumonitis, and she had BCG vaccine, and she got disseminated BCG. And what mom is saying, as she came to the transition clinic, she said, I never thought that Atia can survive and live for 17 years, and you gave life for Atia. And then another important nice story to share is Safiya. Again, she is an 18-year-old girl who had 2 unconditional matched sibling donor infusion in 2008 and 2009. And again, era where there was no newborn screening in the UK. She developed she had pre-HSCT, RSV pneumonitis, and chickenpox, and she had recurrent chest and eye infections. Mom words was overwhelmed. I will lose my child. Uncles and aunts not a good match. And then mom was pregnant. Brother was born, and he is a match. And Safiya's perspective is, I was not participating in any activities post-transplant. And this is, she said that mom was super protective and not allowing her to do anything with her peers. And she's now happy because I can participate in all activities. And what is inspiring about Safiya is the last testimony, which is she said, now I'm studying BTech Science and Health and Social Care, and I want to work in the hospital and give back to people who had my illness. Just one slide about the late onset and delayed ADA-SCID. So there are 28 cases who are reported in the literature who developed clinical manifestations beyond the age of 1 year. And 9 of these 28 had already been diagnosed more than 18 years of age, so in adulthood. And almost half of the cohort had a median time from onset to diagnosis of 18 years. So you can imagine how delayed was the diagnosis is since the onset of symptoms. And as expected, these patients have significant problems, with 50%, according to this pie chart, of the patients have chronic lung disease. Plus, they have also 50% have problems with autoimmunities, plus recurrent lower respiratory tract infection. The problem with the late onset and delayed ADA-SCID is that they might have normal T cells. They will be missed by newborn screening because they will not. They might have normal tracks, or even they will pass the cutoff of the tracks and cracks at birth. So we will miss the diagnosis of them, and the diagnosis is challenging. And when they present, they usually have reversed CD4-CD8 ratio. There's marked reduction in B cell and high IgE. So they present maybe with hypogammaglobulinemia and rather than anything else. But with significant, as you can see, comorbidities. And there is a potential overruling technique, as we said, through the use of the tandem mass spectrometry, looking for the metabolites at birth. And also there is a new technique that Japan is trying to apply in order to look at ADA enzyme activity with what was called high performance liquid chromatography. So diagnose them at birth and start treatment before they develop the comorbidities. And then one slide to reflect on or a couple of slides to reflect on the financial challenges. I just want to show this is the map of the world. What is in blue are the areas where newborn screening for SCID is active and is present and available. What is in yellow, where it is the pilot study. What is in gray is no newborn screening. So I think this map is saying a lot. I don't need really to comment further on the map of the world, but there are so many countries that there is no newborn screening. And you see the continent of Africa, no newborn screening, Greenland, and Mexico. So it's like a large cohort of patients where consanguinity is high, probably autosomal recessive ADA is higher than anywhere else. And this is just looking at the finances. So big ADA, the cost is between 200,000 euros to 400,000 euros per year. and is only available on these countries or continents as I'm just showing them. So not everywhere. And then in terms of the transplant, the cost is variable across countries, and based on the type of donors, I would say what I got is that I think in India the cost for a matched sibling is around 35,000 euros, but for haplos it can go to up to 110,000, and it is one time. And this is the cheapest way of doing the transplant in terms of the funds. And the availability, we all know that ethnic minority, only 25% can have a matched unrelated donor. So the other option for them is a haplotransplant. Then there is always the concern about, can we do haplo outside the specialized hospital? But there is more work now and more data showing post-cyclophosphamide to overcome costing and to improve outcome in patients with important errors of immunity. And the third option of treatment is the gene therapy. So we have the Strimvelis, which is the retroviral gene therapy. The cost is almost 600,000 euros one time if the patient is not going for a second intervention, but it's only available in San Rafael for treatment. However, the patients from Europe, like from the UK or Germany or France, can travel to San Rafael in order to get this treatment. And then there is the lentiviral vector, which is present in UCLA and in Gosh. But again, this is not sponsored by any manufacturer, and it is being produced in these sites by the academic team. So you can expect this is very difficult also to allow availability for all patients.
Darren,
The take-
you can wrap up, please.
Yeah, I'm wrapping it. So the take-home message, big ADA should be initiated at diagnosis as a bridge to curative intervention, whether HSCT or gene therapy, to protect against opportunistic infection. And efficacy decreases with time. Best results in the first 6 months of therapy. And the two big ADA showed efficacy in reversing liver disease, chondrocyte abnormality, which is bone problem, pulmonary alveolar proteinosis, but availability and cost hurdles access to therapy. 3 neurological manifestations and deafness are so far not corrected by the enzyme replacement or the curative interventions. And 4, the new era showed improved outcome of HSCT in ADA-SCID with early diagnosis and advanced supportive care. The gene therapy using Strimvelis through whether the gamma retroviral vector or the lentiviral vector allows good survival, 100% with stable vector copy number, immune recovery, but the cost and the availability in few centers hurdle access to treatment. Long-term safety study is ongoing to monitor risk for transformation changes and risk for malignancy post gene therapy. And we need to have more efforts in order to allow early diagnosis of late onset or delayed ADA defects in order to avoid any organ damage, in particular chronic lung disease and autoimmunity. And just to say that there are 2 things from future perspective is a study that is run by Maria Pia Cicalisi and Andy Jenry, looking at long-term non-immunological manifestations of SCID patients treated with enzyme replacement, HSCT, or gene therapy. And the most important thing is the objective of this study is to try to define an ADA-SCID customized multidisciplinary neurobehavioral multi-organ long-term follow-up program across Europe. And there is another effort by Professor Oliver Harschnitz from Milan in collaboration with Professor IoT Lab in order to study the neuropathology at scale for patients with ADA-SCID and see how can we target the neurological problem. Thank you very much.
Thank you very much, Rin. And now, the Condotti, your comment on this very comprehensive.
Yeah, that's exactly what I was thinking. It's very informative and a comprehensive rundown of the disease and its presentation and the therapeutic opportunities. I just wanted to add a little bit to the diagnosis. In places where UBO screening is available, a baby with ADA-SCID is not very different from any other form of SCID. You cannot really clinically diversify or identify these patients. Where while when if you don't have a diagnosis in the newborn period, the patients with the ADA-SCID become severely sick more than others. And they are metabolically impaired in their ability to detoxify the organism. So you really see a severity in these patients that is more deep than other forms, and it is in the pre-newborn screening days in the clinic. We would see we could predict ADA-SCID based really on at the clinical presentation. It was more severe. One thing that one can do before sending out for enzyme activity and the oxynucleotide determination is really look at the hemochrome, the blood counts. ADA-SCID patients often have a hypereosinophilia and increased IgA levels that is typical of this patient. That doesn't get to the level of an Omen syndrome, but with the hindsight, you can recognize that kind of the finding is present in ADA-SCID patients. The other thing I was going to say is that this disease really is a paradigmatic disease that shows the complexity that this series is supposed to highlight. The non-immunological complications that the urine showed and described are really unique for this disease, and create a presentation that is complex and difficult to manage. Again, in the pre-NDS era, the skeletal presentation, the skeletal finding could really direct the diagnosis toward an ADA-SCID, and this can be useful in places that do not have access to MBS screening nowadays. It's important to say that the screening, the enzymatic activity, and the oxynucleotide determinations are exams that are not available everywhere, but likely can be done on Guthrie cards that can be made anywhere and sent out by mail to places where this is available. So that should not really be a problem in terms of having a metabolic and a biochemical diagnosis, and of course waiting for a definitive genetic diagnosis. Maybe 2 words on therapies. I think I had 7 minutes, or really 5. Yeah, it's great to see this increase. It's great to see what, first of all, PEG-ADA. We know that is a life-saving medications that should be started as soon as possible. Availability of that also obviously is an issue, but the current company that makes it, I would certainly call them up, because they have resources and possibility to deliver this drug even in places where right now it's not available. Right, because they know that this is life-saving and can really give an option for a definitive treatment to affected babies. Of course, we know more about this drug now, and we know that there are limitations in the ability of keeping patients out of trouble, and therefore, as you said, Dream, the definitive treatment is what these patients really should be. Physicians that take care of these patients should be looking for. It is great to see the advances of bone marrow transplantation. The gene therapy was approved in Europe based on the ADA-SCID data, on those data where you show that survival in the non actually identical donors was really non acceptable. Now things are different. Gene therapy at the same time is improving, and therefore now we have these 2 options that are at least in my mind, equivalent. But the big problem for gene therapy is the accessibility. As you said, it's much less accessible than a transplant. And therefore, that's why I was saying it's great to see the transplant has done so much, has improved so much. It provides a life-saving treatment for these patients. It is, from your data, it's clear that gene therapy so far has a survival of 100%, not a successful 100%, but a survival 100%, which obviously is what we would aim for for any disease. Whereas transplant does not have that 100% survival. There is still mortality, and there is event non-free survival that are different from gene therapy. There, I will also offer a word of caution in the sense that transplant data comes from the real life, their retrospective studies, and the real observation that come from patients that come to transplant in any kind of clinical conditions, whereas the patients in the gene therapy trial are selected because these are prospective trials where there are inclusion criteria, exclusion criteria. And so the patients are usually in a better clinical condition. So the lack of mortality perhaps reflects to some extent also that selection bias. And I will stop there because I thought that this was a great presentation and reminding me of a lot of the things that in the past we used to see in the patients, and it reminded me also that how far along has gone the therapeutic world in for this disease, which makes you hope well for the future.
Maybe a provocative question. Let's dream and think that access to gene therapy is the same than to transplant. What would guide your choice to get it?
For me, or Reed?
Also you, Reed,
yep. Go for it.
You mean, so if it is a center and I have access to gene therapy, I would counsel the family and see what they think about whether to go for gene therapy or a matched sibling donor. So it will be the family choice if I have a matched sibling and I have also, or a matched family donor and I have the gene therapy. I think it depends on the accessibility. So if it is a center where there is access to treatment, then yes, we can consider this and we can just give it to the patient choice. But if we don't have access to treatment, I think what is the most important thing is the timing, because I think the clock keeps ticking and we are thinking that a SCID is fine. The SCID is not fine. So we need really to act with a curative intervention. So if we know that we don't have access to gene therapy, we need to go with the best donor that we have for this patient, because if he gets an infection, this will be the most drastic thing and he will have a drastic outcome regardless the type of intervention that we are going to give.
And you, Professor Condotti, no barrier to access? What would you go for?
I agree with this. In a center that has access to both therapies, I would go for gene therapy, just simply because gene therapy has less toxicity. And if gene therapy fails, you have access to a protocol with conditioning, and therefore you have a second option, a second choice. The opposite is not clear that is feasible. At least it hasn't been done, because depending on the conditioning, if the conditioning is performed, the additional conditioning for gene therapy may not be possible. And in a difference with transplant, for gene therapy there is only one studied conditioning. There are not different regimens that one can adapt to the patients if there is some organ toxicity, whereas the opposite for with transplant we know much more about conditioning regimens, and we can potentially switch from one to another. So I would go for that first, but again, some of us are lucky that have this decision to make. Yes.
Yeah, thank you. And moving, you have a very quick last question, because this matters very much to families. Is there research into why neurological manifestation and deafness are not corrected by any of the treatments right now? Is there research on that? Because of course this is daily life. I don't know. I see you nodding, Reem, quickly because we're short on time. But
So this is the last slide that I was showing. There is some research now in Milan about trying to mimic a brain organoid with bloods from taking it from bloods of patients with ADA-SCID in order to understand the signaling defect or what is really happening in the ADA-SCID brain patients in order to try to find a targeted way of managing the neurological symptoms and the deafness. It's work in progress. This is what I can say.
okay. Professor Condotti, any more words on that?
Now, unfortunately, there is an open question that remains unanswered. Some of us were hoping that based on the results of gene therapy for adrenal leukodystrophy, where gene therapy in the bone marrow cells has produced some improvement in the neurological development and function of these patients. The same could have happened in ADA patients, but that has not happened. That means there is not the hematological derived neuronal component that is causing these problems in these patients, but it doesn't tell us what to do next. And hopefully, these studies in brain organoid will give us a new piece of the puzzle.
Okay, thank you so much. Is there any comments?
From my side?
No, just if you have one word to add, because
No, because we will. I mean, I had many questions because it raises. It's such a fascinating disease, and I was very much concerned. Well, interested about late onset cases, which, for example, here in our institution, we follow a few patients, including patients who were diagnosed during young adulthood. So this definitely exists. It's a simple test. You just, don't forget to prescribe as a clinician to prescribe the enzyme activity when you have a patient with a combined immune deficiency. Don't rule out ADA combined immune deficiency in an adult. Right. So that's what now with the gene panels, the exomes or the genomes, we can get some kind of a safety net because there is, as Reem and Fabio mentioned, this enzyme therapy, so that there is an impact of such a genetic diagnosis. But I think it's quite elegant to look for an enzyme activity like we did in the old days, including for young adults.
And we have also a question in the tab. I can see that. Are there any upcoming options for older patients still on ERT?
Well, the options would be or transplant or gene therapy. We don't have data that says that gene therapy in older patients would work as well as it works in the youngest. Some data from the US showed that there was a big difference between the youngers and the olders. For transplant, transplant is doing better and better every day. So there might be a point where we get to a safe transfer for the patients. But in general, also there is a limitation in terms of the results. Reem, I think you might want to add to that. But
okay. And has TRI released, because you spoke of that, the marketing authorization for all types of ADA-SCID or just for the most severe one?
I would have to go back and look at the inclusion criteria, but I'm pretty sure that is for severe, for SCID. So that the inclusion criteria would have a value of lymphopenia that has to determine the diagnosis of SCID. So there will be 50 or 300, depending on what time they define that, but not for the delayed or the late diagnosed patients where the lymphopenia is less severe.
Okay, so before we come to the end of our hard talks, I want to thank you both for this discussion around ADA-SCID management from diagnosis to treatment, to Professor Condotti to your very interesting challenges or comments, more comments than challenges, by the way, and to Dr. Reem, of course, for your very interesting talk, and both for the interesting conversation. We will now have also share a short feedback form which should pop up on your screen. It's very useful for us to know your feedback and hear your comment to continue to improve this concept. Thanks again to all of you for attending this new edition of IPOPI Hard Talks. In a few days, you will be able to watch it on the IPOPI YouTube channel. Don't hesitate to share it as much as you can. And many thanks once again to everyone who joined us today. And a special thanks to our sponsor, Chiesi, for making this event possible. To our audience, stay tuned for the next edition of the IPOPI Hard Talks. We look forward to welcoming you again soon. Thank you and see you next time. Bye-bye.